Vidya, shall we start?
Hello, Gayathri ma'am. Hello.
Yes, Vidya, can we start?
Yes, ma'am. Can you switch on your video so that we can see you?
Okay.
Good afternoon and welcome you all to this echo session. Today we are going to have an echo session on opioids in pediatric palliative care. So it is the person who is going to need no introduction. It is Dr. Gayathri Palat. She is basically trained as an anesthesiologist and later joined in palliative care in Kozhikode Pain and Palliative Care Society. Then she moved to Amrita Institute of Medical Sciences, where she was one of the faculty for 2-year diploma in pain and palliative medicine. Later, she went to MNJ Cancer Institute, and she is working as associate professor there, and she is instrumental in doing many things in palliative care in Andhra Pradesh, including establishing palliative care department in MNJ with a special interest on palliative care, pediatric palliative care, and also she has established Pain and Palliative Care Society in Hyderabad, and there are many more others in her care. So let me welcome Dr. Gayathri Palat, and it's over to you, Dr. Gayathri.
Thank you very much, Sunil. Nice seeing you there. Thank you very much for the kind introduction. Shall I go on directly to the presentation, or are we going to introduce other people? How is it, Amelie?
Yeah, we are
We'll
going
go on further.
Okay. So Sunil, you're going to help me to move the slides. So
Yeah,
can we go to the next slide? Yes. Thank you. So I just want to start with two statements which I've taken from the WHO guideline on persisting pain in children, managing persisting pain in children. They say that there is no other class of medicine than strong opioids that is effective in the treatment of moderate and severe pain. Second slide. They also go on to say that except for the neonatal period, the pharmacokinetics and pharmacodynamics of opioid analgesics are not markedly different from those of adults. The risk of using opioids in infants and children is not higher. Now, most of us are not pediatricians, but we are seeing children every day in our practice, and I think we need to use opioids in children. But all of us, when we use opioids, there's a lot of concern and anxiety about its use. We are never sure whether it's right or how appropriate it is. So I thought in the first few slides, I'll just highlight a few of the pharmacodynamics or pharmacokinetic aspects of opioid, which we should know when we are using opioids in children, before we move on to a few drugs which we describing few drugs which we use normally. We are all aware that at least up to first 6 months of age, the liver is not fully developed in children, so the metabolism is really affected. But it's only up to 6 months of age. They say after that they attain the maturity to go for full-fledged metabolism, which we require to metabolize our opioid medications. Kidney as well, initial few months, it takes some time, so the clearance is decreased, elimination is decreased, so clearance is decreased. Next slide. So if you see the morphine elimination half-life, if you look at the preterm infants, it's quite long, 9 to 10 hours. Term infants, 7 hours. And more than 6 months, it's more or less like an adult, say 3 to 4 hours. Next slide. And so when you schedule morphine, a child more than 1 year, we can schedule as 4 hourly. But we may be required to be a little guarded when we are dealing with a child less than 6 months. Similarly, drugs like morphine, they bind to albumin in the blood before they circulated. Similarly, fentanyl is bound to glycoprotein. So for any reason, especially when you see in babies, if the protein level is less, there's increased concentration of these drugs in unbound forms are more actively available. Their distribution is also, volume of distribution is less in units. So again, that makes it drugs more easily freely available in the plasma. Next slide. We also know that opioids, it blunts the hypoxia and hypocarbia reflex in our body in units and infants. Next slide. So taking into account all these aspects, and much more than that, very often we attribute the pharmacokinetics, that means the metabolism in the liver and excretion in the kidney, as a main reason for our fear to use opioids. But they say that more than that, what is important for us to know is that how opioid receptors are they develop in units in infants and children and then in adults. What they say is that, can we go to the previous slide? Yeah, next slide. Yeah. The mu, next, okay. The mu opioid receptor, it's abbreviated as MOR, is fully expressed, widespread, and functional in newborn sensory neurons as compared to adults. They say it's much more widespread, and normally we talk about pain transmission, we talk about C fibers, A delta fibers, but they say these receptors are present even in other neurons, like even A or the thick myelinated fibers, it is present. Next slide. Because of this, and it's functional. And that's the reason they say that in unit 7 days or younger, there is much less morphine to produce the same effect. And they say more than the metabolism, this is the one reason that we should be concerned about or worried about when we are using opioids in units and preterm babies. Next slide. So the clinical significance is that opioids in units in children less than 6 months means we should start with lower dose. They never say they don't use it. We must use it, but start with lower dose, and maybe the frequency need to be less. It may not be 4 hourly. Sometimes it may need to be used 6 hourly. Now, most of my presentation is based on the recommendation which is given by the World Health Organization on persisting pain in children. So this resource is already shared. And can we go back? When I say next slide, please, it's very distracting otherwise. Sorry. So most of my recommendation is that, and resource is already shared. For those of you not familiar with it, it's a very good resource to refer to in your day-to-day practice. Next slide. Yeah. When you talk about managing pain in children and especially use of opioids, it's the same principle like we use in adults. But here again, I like to highlight this aspect. Whatever opioid you choose, think about the least invasive route, because children, the biggest source of their distress is procedural pain. So we have to think about a route which is least invasive, producing minimal discomfort or disruption to the child, but also taking into consideration absorption from the side. So obviously, by the mouth is the most preferred route for children when we use opioids. Next slide. And of course, the same principle, by the clock, by the ladder, and we have to individualize the treatment depending upon the child we are dealing with. Next slide. All of us are familiar with the 3-step WHO analgesic ladder. It's the same ladder, but more and more people are saying that for children, it's just a 2-step analgesic ladder. They say don't use it's the step 2. Most of the drugs in step 2 are not recommended for use in children. I'd just like to spend a few more slides about telling you why they're saying that do away with step 2. Can we go to the next slide? Yeah. So when you talk about step 2 opioids, most commonly used medications are codeine and tramadol. Next slide. So codeine is a prodrug of morphine. It is, when you take codeine to your body, it is converted to morphine before it produces action. And also codeine is metabolized. varies, how codeine is metabolized varies from individual to individual. If you see here, different races, they're metabolized either very too fast or too slow. So we don't know how it is going to metabolize in the body. The rationale is, anyway, it is going to be converted to morphine in the body. So why to use codeine? Why don't we just use morphine straight away instead of not when you're not very sure how it's going to be metabolized? Next slide. So the recommendation is that because of the safety and efficacy concerns of codeine, because of inter-individual and inter-ethnic variability, it's recommended not to use codeine in children, even though I think it's one of the most commonly used opioid, used very comfortably by most of us as a pain medication and also for as an antitussive medication. Next slide. Even in terms of tramadol, there is a recent thing which I use quite a lot of tramadol, but they say that even tramadol has a lot of inter-race and inter-ethnic variability, how it is metabolized by the enzyme in the liver. So next slide. The recent guideline recommendation I saw by the FDA, they say that children younger than 12 years should not take tramadol or codeine, which can pose this risk for slow or difficult. They talk about different reasons why they're saying, but generally it's because of this variability. We use tramadol because we don't have, not all the centers we have morphine. It's something we have to discuss and talk about how to go about them. Places where we don't have morphine. But definitely if you have morphine, morphine would be the next choice, and no step 2. Step 3, the strong opioids. As I started off by saying that the strong opioid is the recommendation for children when they're in pain or even in pain, children with dyspnea. So we have 3 opioids currently available in India: morphine, fentanyl, and methadone. Next slide. And morphine remains the drug of choice for severe pain in children. It's a world over, I think, the gold standard for treatment for pain in children with severe pain. Next slide. The essential drug list, the WHO essential drug list very clearly states they have, especially this is the essential drug list for children. They have all the formulations mentioned in their drug list. Unfortunately, in India, we don't have different formulations. All we have is tablets, except and injections, of course. And few centers, they prepare liquid morphine, but most of us, we don't have access to oral liquid morphine formulation. But I think some pharmaceutical company, they are going to soon manufacture the syrup. Next slide. When you use opioids, morphine, it's the same like any adult. Use 4-hourly dosage and double the dose at bedtime. And if the pain persists, increase by 25 to 50% of the previous dose. And next slide. And PRN, dose for breakthrough pain. Now this is very important. Next slide. One more. Can we one more slide? Next slide. Okay. So this is the same guideline which we use for adult, but I want to highlight this here that let's always remember to give a very clear instructions to parents about the use of rescue dose. And it's very important that the parents understand it very well, because the children depend on parents for its usage, and so parents should have a clear understanding about the use of rescue dose for breakthrough pain. Next slide. I've not gone into details of various age group and how to start opioids, but generally this is a recommendation for opioid 9 patients in infants. The same guideline given about the dosage. Yeah, next slide. Fentanyl. Again, it is never a first-line drug for use in chronic pain. It is only used when a special situation, when either we want to do opioid rotation, or sometimes when for some reason the child cannot take orally and the parental route is not preferred. Definitely, as like in adult, it's not recommended for unstable pain. And even for breakthrough pain, again we have to take oral morphine. And in a weather like this now, here in the hot, wetty weather, the absorption may be very erratic, and of course, it is very expensive. So it's never a first line for strong pain, for pain management, strong when it is strong pain. Next slide. Fentanyl is used very commonly in babies, infants, and units. We use fentanyl only when there's when we talk about palliative sedation in palliative care. But in the smaller babies, we can think about fentanyl because the advantage is that fentanyl is quite safe even in children with renal failure. The common use of injection fentanyl is when you use for palliative sedation, ICU sedation, and procedural pain. Procedural pain, again, they talk about just giving the dose, in the anticipatory pain, giving it 10 to 20 minutes before the procedure.
Dr. Day come here? No. Dr. Day.
Side effects. Next slide. All the side effects which we see in adults, it's more or less the same in children. So it's the same. Constipation is one of the most common, and we underestimate the prevalence of constipation in children, and sometimes it can lead to a lot of problems. So please be aware of constipation in children. Next slide. And same, nausea, vomiting. Next slide. Drowsiness, and next slide, itching. Yeah, these are all common side effects that you see even with adults, and you could see similar things reported in children too. Next slide. And just like adults, children, we see the same toxic effects. It ranges from undue drowsiness, myoclonus, delirium, and respiratory depression. It's a very late phenomenon which we don't normally see in palliative care, because before that, the child will be confused, drowsy, and the medications are stopped. So these are the same like adults. Next slide. The biggest fear among parents when we talk about morphine, or even for physicians, for pediatrician, is that morphine and addiction, just like in adult population. And again, the recommendation at what they talk about is that appropriate medical use of prescription pain medicine, such as opioids, and properly monitored, does not lead to addiction in young children and adolescents. So we have something to quote or refer to, and we have seen in our practice that it is more, whenever seen, I don't know, in our children, most of the children which we see in cancer, children with cancer, and they die eventually, but we are not seeing this as a problem in our practice. Next slide. What I would be thinking about or worry would be about opioid tolerance and opioid withdrawal. Not to worry, but just to be aware of. They say that prolonged opioid therapy in critically ill children and units for analgesia or sedation can cause tolerance. Next slide. Can cause opioid withdrawal when opioids are weaned or discontinued suddenly. And it can produce opioid-induced hyperalgesia. I don't know how many of you are aware of opioid-induced hyperalgesia. When we think about, remember the metabolism, opioid is metabolized into morphine 3-glucuronide and 6-glucuronide. The morphine 3-glucuronide is produced more in units before they develop the maturity. And probably that's the reason that there's more of opioid-induced hyperalgesia and neurotoxicity, which we see in children. And most of this, if you look at, I have not deliberately put all the mechanism to explain the tolerance and opioid withdrawal, but they share a common mechanism, like how there's a down regulation of receptors and many other mechanisms to explain. But for us, for practical purpose, we have to remember that this may be a problem when you're dealing with opioids for a longer period of time. Next slide. They say risk is more when the baby is preterm, critically ill, and prolonged infusion. They say it's more for synthetic and short-acting opioids like fentanyl, and if infusion is more than 72 hours. So any infusion more than 72 hours, we should taper it down gradually. We should not stop it just like that. And otherwise, they develop withdrawal symptoms, and it may present in various ways, and we don't even recognize all, and the child suffers. Next slide. So they say when you talk, so remembering that, always taper opioids, and if you are not very sure that you are doing it, it's happening well, you can even substitute with another opioid. Switch to if you need it for longer period of time, switch to longer acting opioids, and recognize symptoms early. There are several screening tools they use in various setups where they give a lot of fentanyl infusions. There's an opioid sedation score and in schools to look at the withdrawal symptoms. And if you're using a lot of infusions, maybe it's good to look at those scoring system, have it in place. Next slide. Methadone. Now, this has generated a lot of interest recently because we have finally we got methadone, and as many of us are still learning methadone. But just to recapitulate, it's a synthetic opioid, high oral bioavailability, long half-life in children. It's a very long half-life. It's more potent than morphine when we doses is repeated with longer period of time. Next slide. And next slide. Now, this is very important. We cannot, just like other opioids, we cannot morphine to methadone just like that. Equianalgesic conversion cannot happen. It's little more complicated than what we normally do for other opioids. So, it's recommended that we should be, even in adults, methadone should not be used just like that. It should be used only very specialized center where we can really monitor the patient well, and should be done by a person used to this kind of conversion. Otherwise, it can lead to a lot of problems because of lot of its side effect profile, which can happen. It's very good drug, but the side effect also can happen. Problems like prolonged QT interval or much more sedation than other opioids. Next slide. So methadone, it's never again a first line. It can be used. It's one of the opioid of choice in opioid rotation. A lot of discussions about opioid rotation in children. I think probably for the reasons that there's a reason like opioid tolerance, opioid hyperalgesia, and when you need it for longer, difficult pain syndromes, when you have multiple complex pain syndromes happening together, sometimes morphine is not helpful. In that situation, we may have to rotate opioid. There's a lot of detailed discussions around opioid rotation, which is beyond the scope of today's discussion. We can discuss this as a separate topic. And they say that tolerance is much less in methadone, probably because of NMD. Methadone has additional action on NMD receptor, and that's the treatment of choice, to use the NMD receptor blockade drug, suppose they develop tolerance. Next slide. So to conclude, when you're using opioids in children, after the neonatal period, the pharmacokinetics and pharmacodynamics of opioid analgesics are very similar to adults, and it's safe to use. That's something we have to begin to understand, that we can use opioids in children. Next slide. But when you're using the opioids, oral morphine remains the gold standard, and we talk about the two-step strategy. Start with paracetamol or non-opioids, and if you have morphine, go straight away to morphine. At regular interval, dosing should be done with the proper instructions about breakthrough pain and adapt treatment to individual need of the children. Thank you. So this is the guideline which I recommend to follow. It's very simple and very useful for all our clinical practice.
Thank you, ma'am. Shall we move on to discussion about the didactic? And is anyone having any questions for Dr. Gayathri? Can you please? She will be available for another 5 minutes, maybe. Yes, because she has to go away somewhere. So anyone, if you want to direct a question to Dr. Gayathri, please. Thank you.
Hello.
Iqbal.
Hello, good afternoon, everybody.
We can hear you, just say.
Okay. Gayathri Madam, nice to see you after a long span of time. And thank you for your very nice presentation. I have only a question, Madam, to you. Nowadays, we are starting to get few children in our hospital, Madam. We have a 4-bedded children ward here, 5-bedded. So they are in dormitory. So nowadays children are coming out now. Still that sometime in children it is difficult to give the tablet from. Okay, madam. It's 10 kilo, 12 kilo babies. It is very difficult to give the tablet, and also there are some children who can, who can swallow. There is no need to use the IV morphine. So my question is that whether in these cases, madam, whether we can break the tablet, make a solution and give the tablet to the children, madam.
Dr. Iqbal, nice to see you. A very valid and very important question. Unfortunately, we don't have pediatric formulations for opioid medications, especially morphine. And yes, we also do that. We see children where we may need to give morphine as low as 1 milligram per hourly. So in that situation, we break the tablet, crush it, and we make it into syringe. So, for example, 10 milligram one tablet in 10 cc syringe, and each ml will be 1 milligram. Like that, we try to do. But very important, how you instruct the family to do it. If they don't do it well, either it can be over or it can be less. So the instruction to the family that how it should be crushed properly and how it should be dissolved in the media, water, whatever you're using, and shake well every time. Because if the sediment settles down, it can be tricky. So yes, we don't have a formulation, but it's the best we are doing right now with oral opioid medication.
Thank you, madam. Thank you.
Gayathri, Rajeshri here. Am I audible?
Yes,
Hello,
ma'am.
Raj.
And Gayathri, what will be your recommendation of opioids for non-cancer pain in children?
Again, Rajshri, it's a very good question. For non-cancer, first of all, I would still, if the child is having severe pain, I would go for morphine. That would be my stand. But having said that, whether it's a cancer or non-cancer pain, it's a big responsibility on us as to how we prescribe, in what way we may prescribe, and what kind of documentation we do, how many tablets we give to the family, and what instructions we give to family, and how we follow up. Everything is very important. So I think it's a universal precaution, they say universal precaution for opioid prescription, which we should be standardized and followed everywhere, whether it's cancer or non-cancer. I don't know whether Rajeshri, is that your concern about the recent uproar about use of opioid in non-cancer situation in the West? Is that the reason that you asked this question, or is it because of other disease-related concern?
It is not the disease-related concern, because when I recently attended one EPIC pediatric workshop, and actually in the modules which were sent by them, they have specified that opioids should not remain as a mainstay of treatment for non-cancer pain in children, because we have to consider other modalities with equal importance, and if possible, we should promote that instead of maintaining the patient, I mean the child or opioids for a long time. I don't remember what were the exact reason which they have quoted for that, because I read that because I also found it very, confusing, because that is not how I have learned.
I think Rajesh, the concern is purely because of this worry about diversion misuse where it is available plenty. I think for me it would still be depending upon the pathophysiology. We would still try other modes of treatment, but end of life or advanced, whatever the illness is, if the child needs opioids for pain, sedation, or breathlessness, I think I would still go for it. I have to hear from the expert sitting there.
Can I ask, are you sure the wording was mainstay and not first name? Because usually American Pain Society came up with a recommendation that's generally quoted, that whether it's adult or child, for persistent non-cancer pain, opioids should not be the first line. Possibly not mainstay, I make that change, because if the first line or even second line medication do not control it, whenever possible, whatever be the diagnosis, from the patient, and in this case, the family, have a written consent. They understanding that there can be dependence, and they continue to use treatment.
The volume was not clear. Can Dr. Rajshri please explain it again what sir said, or sir, would you like to repeat the same comment?
I was suggesting that the statement that it is not mainstay treatment may not be appropriate, whether it is child or adult. Am I audible now?
Yeah.
Yes.
Whether it's child or adult, the current recommendations, especially after a publication which is quite disputable, said that dependence following long-term opioid therapy in non-cancer pain can be as much as 10%, which includes more than addiction, even physical dependence, I think. Following that, the American Pain Society came out with some guidelines, which is generally widely quoted. The recommendation is that opioids should not be the first-line medication for persistent pain. Persistent pain is the term. Persistent pain in non-cancer patients. So if it is not cancer, it is not a first-line medicine, that's all. Suppose the situation warrants, the recommendation for adults is that opioids, prolonged opioid therapy of more than 3 weeks should be started only with the written consent of the patient. The patient undertaking to write down and sign that they understand that it may cause dependence. In this case, understandably, it has to be the parents or the guardian who makes that signature. So I repeat, if nothing else relieves the pain, when include a vascular pain, if non-opioids do not relieve the pain, then you make an assessment and even undertake long-term therapy, risking the possibility of dependence. Want a cup of tea?
One question, madam. One of my nurse was asking a question, Rakhi. She's asking a question that pediatric, they have, the formulation comes in a very palatable preparation, sweet, all the pediatric, whatever you say, Calpol or cough syrup. So she was asking me whether they can mix some sugar along with the morphine preparation to make it more palatable, whether it is justified in doing this.
Iqbal, that's a very good question. Even I always think about that. So what we do, yes, we do mix morphine in try to do it in palatable solution like a fruit juice or a sugar solution so that the kids they drink, otherwise they refuse to drink. But we've not done any study about its potency or efficacy when we do such kind of dissolving in different preparation. We don't know how effective it will remain in terms of its potency or efficacy. So I don't know actually, but we do that. And most of the kids are fine, we get pain relief, so we just go doing that every day. So I don't know actually the answer, whether it's do we do that potency in any way. Yeah.
Okay. Thank you, madam.
Any questions for Dr. Gayathri? John, you want to say something? You have to unmute yourself.
Yeah, I was just starting to type something, but in our practice, and I sometimes consider the clinical standard as what is our standard of practice, even when there isn't clear evidence about, as you were saying, um, evidence about what actually happens with different diluents, different dilutions. But it's very common in our standard of practice to, with children, to use a sugary solution or a chocolate milk solution are the two things that we do. Again, I can't quote evidence about it, but fitting into what different practices do, and without evidence of decreased efficacy or without occurrence of harm, we do it regularly. I think on that basis, you would be on safe ground.
Thank you, John. Okay. Shall we move on to the next case presentation? Dr. Gayathri, thank you for your presentation, ma'am, and thank you for taking time out for doing this.
Thank you, Vidya. Pleasure meeting all of you. Thank you. Bye-bye.
Spandana, are you ready to go?
Are we audible?
Yes.
Yeah. Good afternoon, everyone from MNJ Hospital, Hyderabad. So today's presentation is going to be by Dr. Spandana. So I'm just going to introduce her and our team here. So my name is Dr. Jean Jacob. I'm a consultant in palliative care working from Hyderabad. On my left, we have our pediatric palliative care nurse, Dorothy, and our presenter is Dr. Spandana. She's a pediatrician, MD Pediatrics, and she's joined our program as a pediatric palliative care fellow. So we're going to describe a case that is relevant to what we just heard from Dr. Gayathri about persistent pain in a child with cancer, and how we try to deal with it, and we can discuss how it can be done better. So I'll just hand it over to Dr. Spandana.
Hello, good afternoon, everybody. The next slide, please. So here today I'm presenting about a female child who's 13 years old and she weighs 35 kgs. She was referred on the day of admission to us. She was not diagnosed at that point. The diagnosis came a few days after she was referred to us. She came with severe pain. Next slide, please. The pain, it was very severe. It was in her right hip and foot and also right ear. The right hip pain, it is somatic, 10 by 10 pain, aggravated by movement. It was relieved by lying on the left side because the tumor site was on the right side. It was associated with swelling of leg, which extended up to her vulva. And her right foot, she had burning type of pain, neuropathic pain. And right ear, the pain, it was radiating to neck and scalp. And she also had a slight swelling of her face. And she also complained of hyperacusis. Next slide, please. The patient was bedbound because of pain. All her toilet needs, urine motions were met through the bedpan. She had decreased appetite, disturbed sleep because of pain. And she also complained of burning micturition and constipation. Next slide. During our assessment, the child is conscious and oriented. In the nursing assessment, we found 1 centimeter bed sore on her back. We tried Foley's catheterization, thinking that less movement will reduce her pain a little, but it was failed because of vulval edema. Next slide, please. Her investigations, which came later, indicated nodular opacities in left lung, and the pain in the ear could be explained by the hotspots in the skull, probable metastasis. Next slide, please. So when she was first referred to us, we started her on morphine 7.5 mg, QFOH, and double dose was given at night. There was no relief of pain. Next day, we doubled the dose, and we also added ibuprofen so that it might reduce the inflammation. On the third day, we started, there was no much relief. So we started her on amitriptyline night dose, 25 mg. On the fourth day, the whole team reviewed her and we started her on steroids, which we continued for 5 days. And we also added ketorolac 30 mg IM doses. In the second week, she was willing for injections at this point. So we have given a trial of 1 mg morphine subcutaneous dose. Her oral morphine was increased to 20 mg and amoxicillin was increased to 50 mg from 25 mg. Ibuprofen from TID, we have made it QID, and injection morphine 0.5 mg IV doses were advised SOS. It was the even then there was no relief, so we had to convert the oral dose to IV 2 mg Q4H, and we added even lorazepam in the night. Intermittent morphine trials were given with no relief. We increased the injection morphine to 3 mg IV Q4H, and we also added valproate at this point. And because of the lack of sleep and there was some suicidal ideation and a lot of depression in her, we thought adding psychiatric medications might help her. And we added a combination of escitalopram 5 mg and 0.5 mg of clonazepam, 1 tablet in the night. Next slide, please. In week 3, we increased injection morphine from 3 mg to 4 mg Q4H, and we started fentanyl patch 25 mics. After a day, we changed the injection morphine to SOS doses. And even with that, there was no relief. And the next patch, we increased to 50 mics. And we also planned to start oral ketamine. But at this point, she was discharged and they were not willing for hospice admission and they went home. So we did not start oral ketamine. And we sent the child with fentanyl patches and ketorolac injections, IM doses 15 mg to be taken at home if she has severe pain. On 13th, chemo was started for her, that is after a week of admission. And they referred her to radiotherapy also. But the mass, which was at the pelvis, which very huge. So they said that there might be more radiotherapy toxicity and it was deferred for some time. Next slide, please. Along with the physical pain, the child had emotional and psychosocial issues that she has to pass urine and motions in a bedpan in a general ward where there are a lot of other males. She also had suicidal ideation. A normal, calm child has turned into an anger child, thinking that her parents don't care enough about her. And she also had those feelings that she's stuck in a hospital when she has to give her final exams. And there was a lot of fighting going on at home, and there were all these other issues which we thought might be adding to her pain. Next slide, please. She is the second child. She has an elder and a younger brother. Parents are daily wage laborers, and the child is attached to the father, but he has to go to work, and mother was the primary caregiver. Next slide. So my question is, how could we have managed the child's pain in a more quicker and more effective way? Because it almost took 3 weeks for the child to get a good relief of pain. So yeah, that's it.
Can we exit the share screen? Thank you. Thank you, Spandana. Now, can you please share your experiences with Dr. Spandana, or any questions, please kindly share. Dr. Raji, any comments about this case?
just want to ask you whether were you able to control the pain even after radiotherapy or chemotherapy?
Sorry, can you repeat the question? We couldn't hear.
Were you able to control the pain after the definitive treatment with radiotherapy or chemotherapy, or how much did she had to suffer? How long for getting the pain relief? Even
She
though
was referred to.
you have done
Sorry, go
your
ahead.
all the best.
So when she was referred to us, there was no diagnosis and the treatment was not started. For that to happen, it happened after a week after she came to the hospital. So at this point, there was no intervention from oncology side and it was totally under palliative care. And after the diagnosis, they were, even then they did not start the treatment immediately because they were thinking about the side effects because of the tumor size. So it was almost 10 days before they started the treatment. And all the time, the child had no relief from any oncology medications. By the time our medication started to take effect and the chemotherapy was also working, it was third week into her admission. So that is the question, right? About the oncology medications helping with the treatment.
Yeah, that was one of the questions. Whether were you able to help her with oncology treatment? Did her pain decrease?
We weren't able to reduce the pain either with our pain treatment, neither with the oncology treatment. From the oncology treatment, basically they started the first cycle of chemotherapy. They started the first cycle of chemotherapy at a few days after the admission. A few days after that, we also referred to radiation oncology, but they said they won't touch the patient now. They'll, after 2 cycles of chemotherapy, they'll consider for radiation. For the next 1 month, when she was undergoing the first cycle of chemotherapy, we kept trying to escalate the pain medication, both the opioids and the adjuvant pain for neuropathic pain, and as much as we could escalate. And still, by the time she was discharged after the first cycle, we were not satisfied with how we were managing her pain.
Okay, thank you.
One of the things that crosses my mind, one, how comprehensive you were in assessing her pain, all of the things that children experience, being pulled away from their education, their family issues, truly comprehensive palliative care. The second thought that crosses my mind is that you chose several less toxic agents that have the ability to impact bone pain, that being steroids and NSAIDs, and aggressively used those along with starting opioids. You expressed discomfort about how long it took to get her pain under better control. And I wonder how I saw the data in your presentation, but I wonder how you thought about how fast you could titrate for opioids as you were making day-to-day decisions. What guidelines did you use, or how did you think about how much can we titrate her opioids today and the next day?
Thank you, John. So we used to daily do a numerical rating scale assessment. She by the end, as soon as she saw us, she'd be giving us numbers, and usually it was between 8 and 10, and she'd be crying, and there was a lot of psychological pain associated with that, because we found that when we were there during the daytime, she would complain less, and then when we came the next morning, she'd again be like, the whole night she was crying in pain, and the family had a tough time. So we were assessing daily and trying to escalate, because it was troubling for us too, because we want to get more aggressive, because we were not able to get her from a severe pain to at least to a moderate pain. You wanna add?
Yeah, according to the guidelines, we can change the opioids every 24 to 48 hours. But we were doing at the 24-hour rate itself because her pain has not come down even by a single number. So we thought whatever we were giving was completely insufficient.
Yeah, again, it sounds like you were very comprehensive. I think in the guideline that we follow is if the pain at a current level of therapy is felt to be still moderate, we would make a 25 to 50% dosing increase. And if the pain were moderate to severe, we would consider a 50 to 100% dosing increase, especially in the setting where she's inpatient and can be observed. So those are two things that cross my mind. It also, interestingly, does bring up, doesn't it, the issue of methadone for somebody who is going to have pain like this, and sometimes the benefit of an agent that is as different as methadone is. And also your comments about her total pain experience at night with her family, all those things. It's a very comprehensive care that you've provided.
Abhishek, you deal with a lot of pediatric patients. What is your experience regarding similar situations?
Yeah, firstly, we start with the WHO ladder pattern. Firstly, we don't go with the severe pain. We start with injection morphine, and whatever patients we get, it's really helpful to start with the third. Like if the pain severity is more than 6 out of 7 out of 10 or 7 out of 10, directly going to the third step proves to be very helpful. But since we also provide like end of life care, so at that moment it becomes difficult convincing the parents for staying at our center, because most of them wants to go to the emergency for the treatment, because they consider tertiary care hospital like providing with the end of life care or whatever intervention that can be done. So basically beginning with morphine for severe pain proves to be very helpful for pediatric patients.
Dr. Raji, yes.
Jean, I would like to know, in your presentation, you had mentioned that you have started escitalopram. And considering that she's having depression, am I right?
That is why we have started escitalopram.
So were there any specific tools to judge that the child has gone into a state of depression? And was it part of the adjuvant therapy, or was it a specific medication meant to manage depression?
It was given specifically to manage depression, because every day when we spoke to her, she would talk about committing suicide, and that she couldn't control the pain, that whatever we are giving is not helping with the pain, and she has been shuttled to various other hospitals prior to coming here. So we thought there is a lot of role of depression which is adding to the emotional pain, and that is why we have added escitalopram at this point. Amitriptyline was already started, and it didn't help much with the depression part, but it helped with the neuropathic pain a little.
It seems to me there could be double benefit from using the SSRI in that situation, the citalopram, for hoping for some increased effect with both with neuropathic pain management and trying to support the brain chemistry with the depressed mood that she's experiencing. Your questions when you started asking were how could we have gotten her pain under better control more quickly? And I can describe what we might do in our setting here in the US, and then of course it has to be adapted to your setting and what your resources are. One of the things, talking about the guidelines and 24-hour increases, I don't want to suggest at all that people not pay attention to and follow guidelines, yet sometimes it's a good idea to be sure the guidelines are serving us rather than us serving the guidelines. And what I mean by that is that in this rather unique situation where a young woman is in such extreme pain as this, and with initial doses not controlling her pain very well, in our practice, we would have, first of all, we have access to continuous infusions of morphine, and sometimes that's what fentanyl accomplishes, I think, the equivalent of that in your practice. But in our practice, we would have sat by the bedside for several hours, and we would have given Q15 minutes, every 15 minutes dosing of morphine, and if monitoring this patient all the time, then increasing maybe even every 1 to 2 hours that dose of morphine, observing vitals, observing sedation, all of those kinds of things. And then over the course of the day, as we went to those higher doses, then if we found a dose where the pain was relieved, we would try to add that back into her regular dosing, and then continue her PRN dosing. So part of me feels uncomfortable saying to you in your environment that aggressive approach, or what we call a pain emergency, if those things stray away from your guidelines and how you feel you can practice safely and effectively based on your experience, based on expectations, then it may not be possible for you to be that aggressive. But I wanted to tell you how we would do it in our practice would be to literally be giving every 15 minutes, and if it's still severe pain in the next hour, we'd be doing a 50 or 100% increase till we found that dose. I hope that's helpful. I don't know how you can do the logistics of that in your practice.
Yeah, so we tried doing something similar to that with the logistics that we had and the resources that we had. So there were some days where in the morning when we go on rounds, we'll stop by this patient, we'll do a morphine trial, and then we'll go for the rest of the rounds. And after that, we'll come back to this patient, do another morphine trial. After lunch, there'll be another morphine trial. We couldn't actually sit with the patient for several hours just because the logistics didn't work out like that. But as much as we can adapt to that in our setting, we did try to get as aggressive as what you're saying for this patient.
Is there any role of intervention in this kind of patients for quicker control of the pain? I mean, the tumor was situated in the upper limb, isn't it? Right upper limb, you were mentioning, Dr. Sneha. So, wouldn't you could have taken the help of a interventional pain specialist, I mean anesthesiologist, for giving some nerve block in the upper extremity, provided the tumor is situated in the upper limb, so for quicker control of the pain. Anything, something like we could have done.
It is lower limb, I think.
The tumor was in the right hip. That was something we considered, but the thing is, the pain that she has, it isn't just localized to the right hip. That is just one component. There was another component of the pain that was a kind of burning, shooting sort of pain going down her leg, which was also severe. And there was another component which was in her head and neck, which was also part of the metastatic spread. So but yeah, maybe that I'm not really familiar with what sort of interventions we could have done in these situations. Maybe for the right hip pain, we could have considered some intervention. Maybe someone from the panel can further elucidate on that.
So, as an anesthesiologist, you routinely do few interventions, suppose epidural block and spinal anesthesia force. So, similarly, if the patient has a pain in the right hip, you can give a epidural block starting at the level of L4 and L5 with a very low concentration of anesthesia. It would have given a very, very quick pain relief. And you can always put a catheter and top up the dose, go on giving. So, as far as the pain in the right hip is concerned, it is a weight-bearing area. Patient need to mobilize, and there will be more pain because patient has to mobilize, and it is the big joint, weight-bearing area. So, the use of epidural analgesia with the help of bupivacaine or lignocaine, with the addition of some low dose of morphine, would have given a very, very good pain relief in one hand. And also I understand the difficulties. He was having head and neck pain, so probably it would have been difficult to manage with the intervention. But I was wondering that at least this pain could have been controlled very nicely, and remaining pain could have been taken care of. What I have done very wonderfully. This is just my, I think it would have been helped.
Yeah, I think that's a good idea. Specifically for the lower limb, that right hip pain, and maybe an epidural with low concentration, so that it just blocks the sensory and not the motor component. Yeah, that is something we could have considered, and maybe we will consider, because the patient is right now readmitted for the second cycle of chemotherapy. So we are going to revisit this patient and see what we can do now.
And also in our center, because I am an anesthesiologist, I take very advantage of the nerve block to mitigate the pain. Suppose if you get any pain in the fracture in the upper extremity, you can choose to give a brachial plexus block. The thing is that patients are in very severe pain. And as soon as you give this block, you just buy the patient heart, They will just, tell whatever you will do, it will build a very good rapport, and it will mitigate the need of all these analgesics. We have used number of analgesics. Probably the burden of disease was very more high, and because the patient was not started on any cancer treatment. So as far as possible, if you have the expertise available nearby, you can always take the help of the nerve block intervention. But it is very, very good to see that the titration, as well as the history, as well as the drug titration we have done, it is very, very wonderful, especially in a setting where you don't have an anesthesiologist. Everybody may not have skill in anesthesia. There will be many places where an anesthesiologist will not be there. But what you people have done, the titration, the drug, the steroid, and the nerve, this is very, very good. What learning and seeing also. Thank you very much.
Thank you.
Jean, refresh my memory again. Was ketamine part of her regimen at some point?
So just before the patient got discharged, we had run out of everything else. So we were just going to start her on oral ketamine as an NMDA antagonist to see whether that would have some effect, but we didn't get to do that. That was kind of the last thing we were going to try.
Yeah, I don't know if that will be something that would be helpful during her present or her upcoming admission, but it did cross my mind. The other thing that crossed my mind, and again here we're focusing on these technical, medical, physiologic things, but as our colleague just said, all of the things that your team, I'm sure, was doing for support for psychological, spiritual, emotional support. Those things, I'm sure, make a great contribution also. But it does cross my mind, and we had done it several times in Trivandrum, was a trial of lidocaine infusion to see if there was value in that, especially in the setting of a component of neuropathic pain. So that crosses my mind for future reference.
Dr. Raji, what is your comment on this?
If all other measures, if I have felt that I am exhausted, then I also would have tried either lignocaine infusion or ketamine. I would try first with ketamine because I think I can send the patient away home with oral ketamine as well, because if I start doing a lignocaine trial, then I would be in trouble. Then what kind of oral medicine she has to be put on? So in my context, the place where I am working, I would give preference to ketamine with respect to lignocaine, provided if I have exhausted all other options. And still I am a bit confused about starting antidepressants just because the girl expressed agony because of the physical pain. And if she had expressed that she's not, I mean, she doesn't want to live anymore, that is purely because of pain. I mean, whether that we can consider it a part of expression of depression, I am still doubtful.
Has Dr. Hari Prasad joined us? Because I haven't met him. I'm not. Sir, have you got any comments about this patient's treatment, sir?
I think, thanks a lot, madam. But I think I'm new to this area of management palliative care. So I think my experience with children suffering from malignancy is less, but still, I think I will like to join with Dr. Gayathri, as she said. I'm really doubtful whether they could have gone for antidepressants. That's the first thing. And second, I think considering the nerve block, I think that was a real option. Rather than getting exhausted regarding all this morphine and fentanyl, I think they could definitely try for
Thank you, ma'am. Jean, any more questions from your side, or shall we summarize and move on to the next case history?
No, we're fine from our side.
So from the discussion, what recommendations have come up is we have to try all options of our oral medications, role of ketamine to be considered, and then maybe role of nerve block or the epidural analgesia can be considered. Another question which I had in mind was, I saw that you have given Brufen, ketorolac, and at state some other NSAID along with steroids. You should also think about the toxicity concern about this. And in children, steroids may lead to behavioral disturbances as well, which is mentioned in some of the literature. So kindly look into that as well. Otherwise, we will send the summary for this case presentation and see how we can move on. Maybe next week, next session when we do the presentation, can you do a follow-up on this case with us? Is it okay if you can do the follow-up and tell us how it helped?
Yeah, for sure, because the patient is just readmitted today. So again, we are going to go through this whole process. So we will give you a follow-up on the next session.
Okay, thank you, Jean. Thank you, Standana. Yeah. Dr. Namrata, are you ready to do the presentation now? Yeah. Can we have the slide, please? Vishnu, can we have?
Hello, good afternoon, all of you. Am I audible?
Yes.
Hello. Am I audible?
Yeah, we can hear you.
Okay. Good afternoon, all of you. I'm Dr. Namrata from Gujarat, Karamsad. I'm presenting a case of a 7-year-old female, is a Hindu housewife, is having upper motor neuron, lower motor neuron paralysis. Next slide, please. She was diagnosed as having pure motor paralysis 2.5 years ago. In the beginning, she was having weakness of upper limb and lower limb. In the beginning, she was able to walk with support, and she was completely bedridden since 1.5 years. She is quadriplegic now. She is having bowel and bladder control. She can swallow easily without any difficulty. She was referred to our palliative care OPD from September 2016, and since then she is completely in palliative care. She had complained of right shoulder and both arms and leg pain when she was presenting her OPD. She has complained of decreased appetite and decreased taste sensation. She had disturbed sleep due to pain. She said that burning sensation was starting after 2 hours of sleeping, and she needs to change the position to get relief from that pain. But she was not calling any family members because she herself was not able to change the position. So she needed to wake up some family members, which she did not like. Her palliative care performance is 30%. Because she has reduced food intake. She's completely bedridden. She was saying that she does not like eating, and the taste sensation was decreased. In the detail, when we assessed the pain, she was saying that she is having pain in both legs, both arms, and right shoulder. And on this follow-up visit, she had also complained of pain in the back. The pain score was 7/10, which was throbbing and creaking type. Actually, she was not able to describe the pain fully. She was saying in the broad terms, and this is what we have made out from that terms. Like she was having throbbing and creaking type. Okay. And the back pain was burning and aching type. She is living with her husband, mother-in-law. She has 2 sons and 1 daughter-in-law. Her family members are taking good care of her. There is no major financial issue for the family. Family is very cooperative for any treatment, and all except her mother-in-law are employed in the family. So between 9 to 5, all family members are employed. So she lives with mother-in-law and the maid, who is taking care of her. Very religious person. She likes to watch religious programs on TV, and she used to read religious books. But when she after becoming quadriplegic, she is not able to change the TV programs and hold the books. So she has stopped reading books and watching TV. She feels that she is a burden on the family. She used to be very active in the household activities before developing the disease. So it is very difficult for her to accept the condition on becoming completely bedridden. On past treatment history, on presentation was on gabapentin, escitalopram, and tramadol plus DCM from neurophysician. After assessing her pain, we have started her on morphine 5 mg for early and continued the old medications, which are gabapentin, escitalopram 10 mg, and tramadol. And then she required increasing dose of morphine and was stable at 15 mg for early. So after that, we shifted her on morphine 25 microgram patch, but it was not sufficient for her. So we shifted her to 2 patches of 25 microgram and morphine for breakthrough pain. But she required morphine 5 mg for early with 2 patches of fentanyl. After that, we have stopped applying fentanyl gradually, and the pain intensity is same as it was with fentanyl. She has access to airpad, but she is not very comfortable to use it. She feels too hot in it. Referred her to psychiatric OPD to rule out depression and sent her for psychological counseling. Current treatment history is she is taking tablet morphine 5 mg for early, tablet bisacodyl 10 mg HS, tablet gabapentin 100 mg 2 times a day, tablet diclofenac 50 mg BD, tablet pantoprazole 40 mg OD, tablet baclofen 4 mg HS, tablet escitalopram and alprazolam are prescribed from psychiatric department. And we have advised physiotherapy and back care. Next slide, please. Our main concern is even after providing high doses of analgesics and psychological counseling, it is not comfortable. What can we do for the management?
Can you repeat the question, Dr. Namrata, to the audience?
Actually, we have provided her high doses of analgesics, but she is still not comfortable with that. Whenever we start a new drug, she responds very well with for around 1 week, and after that she starts complaining the same. What can we do further for this patient?
Namrata, what I noticed was the patient is currently on 5 milligram of morphine Q4H, but previously have put her on fentanyl 25 micrograms to 2 patches, right? So that's equivalent to 50 micrograms. How did you calculate the conversion there?
Earlier she was stable on 15 before. So 15 and now 37.5. So we had put on 50. She was on 50 and symptoms were almost same. And gradually they decided to have only one patch. Symptoms are still the same. And then we thought, okay, gradually if you are not feeling, we'll take it off. So you advise them to stop morphine also, no? But they are just continuing with that.
So, as far as my understanding, 50 microgram of fentanyl patch is equivalent to 20 milligram of morphine Q4H, right? Can you unmute yourself? And
so 15 would be 37, right?
I didn't get it.
When we started around fentanyl, she was on 15 milligram Q4H. So that would have been equivalent to 37.5. So only option we had is 25 2 patches.
Right. But how come the patient was on 15 milligrams and there was no pain relief, and then you decided to put her on lower dose of 5 milligrams? I didn't get that conversion there.
Because she was not comfortable, they themselves decided to take off this thing patch. They told, okay, even we are not getting any relief with this, we'll manage without patch. That the patient, we wanted to continue for some more time, but they don't give, because for 2-3 weeks she will be better, then her symptoms will be back again. Almost so they decided to stop.
You mean the pain
Dr. Raji
decreased when you brought it down to 5 milligram? Was she comfortable? I mean, why did the question all of us, I guess, have here is from that dose of morphine, it came down to 5 milligram Q4000. Why was that done? Because that is a significant reduction in dosage. So why was it done? I assume that's what is playing on most of our minds.
Actually, when we had continued 2 patches, but her son himself decreased to 1 patch, and then he has stopped applying the patch. And the pain intensity was same. Actually, we are predicting that it is more of a psychological kind of pain. She doesn't respond to any treatment. If you withdraw any treatment, she doesn't complain again. Right now, the condition is like that.
So does she feel drowsy? Is there anything else that those are markers that you are high on the morphine dose?
No.
Yes, ma'am, Dr. Raji. Unmute.
Here I am not clear whether the current morphine dosage which she was receiving, whether that had given her enough pain relief, and what was the side effect profile. And if we could increase morphine dose, and if the pain is responding to morphine, and if she can tolerate further doses of morphine, our first option should be escalation of morphine rather than trying with fentanyl. And other thing is that, have we tried paracetamol? So can we have a trial with higher doses of morphine and paracetamol, and then see the effect, and then thinking of other kinds of analgesics?
Can you unmute yourself, Namrata? Can you repeat?
Myself?
Actually, we were giving her 15 milligram morphine more early. At that time, she was comfortable with that. The only problem was between 9 to 12, nobody was there in the house. So she was having difficulty in taking the tablet for early. That's why we have shifted her to fentanyl patch.
Yeah. Have you tried paracetamol, as Dr. Raji asked?
No, we haven't.
Several things cross my mind, and I'm sorry I'm having difficulty understanding some of the responses. There's a lot of echo. To my mind, one approach might be to determine, is the pain opioid responsive? And again, pardon me, I'm having difficulty understanding some of the responses. If the pain is opioid responsive, then to my mind, the question would be, which opioid is it responsive to? Is it responsive to morphine, or is it responsive to fentanyl? And is it possible to continue either of those medicines? I heard what you were saying about the family involvement, etc. But that's one thing that crosses my mind, is just the general question: is it sustainably opioid responsive? Another thing that I heard is that she, for many different things that you try, maybe it seems to work for a little while and then not work for very long. To my mind, that's the hallmark of placebo effect. So that improvement that doesn't sustain for more than a week. So I don't know yet if her pain simply isn't opioid responsive or not. And if there's difficulties in the home with her being able to get the adequate dosing, etc., to my mind, I would first try and answer, is it opioid responsive? If it isn't sustainably opioid responsive, then one thought that crossed my mind would be her gabapentin dose is relatively low. That might be something that could be tried again. Another thing that I wrote down is she'd be an excellent candidate for methadone when it's available, given her type of pain. I wonder about the counseling that she received, if it was from experienced people experienced in palliative care, like the social workers that I've met at Trivandrum and things like that. Because I think psychologists or psychiatrists who don't have experience with palliative care, I don't know in your setting if they're able to talk to patients about the kind of depressed mood that they experience because of loss, because of symptoms, things like that. I mean, it sounds like this woman may not have endogenous depression per se, but she may have depressed mood due to poor quality of life, loss of life as she expected it. So Yeah, I've encountered in my own practice some therapists who are skilled in dealing with that because it's different in palliative care. So those are the things that I'm wondering about. And again, I'm sorry, I'm just having difficulty understanding if we've really established if her pain can be controlled with opioids or not. Thank you.
Dr. Raji, do you want to add any further comments to that? Dr. Johns. Thank you. Iqbal, what is your opinion on this?
I also agree with what Dr. John has said. Because it is a problem with nerves and muscle, as you understand, motor neuron disease. It has nothing to do with the one pain. So two things are important here: one nerve and the other one is muscle. So we have to strike the drugs by keeping these two things. As Dr. John said, that first we have to see whether it is opioid responsive or not. If it is opioid responsive, I would like to increase the dose of the opioid if the patient bear the opioid. And second thing is that because it is a nerve, we have to add some nerve-like thing. We have to add gabapentin. And to me, if I think that the patient has too much of chronic pain and emotional component there, I would like to start with an imipramine rather than start with gabapentin. Imipramine will take care of the neuropathic pain as well as it will take care of the emotional component. I would like to start with 25 milligram HS, titrate the dose for 3 days, build up 50, 70, 100 and see the response. And of course, gabapentin, what doctor has used here is 100 milligram TDS. I don't know the weight of the patient, but the gabapentin definitely the dose is low. I think here we could have built up the dose to about 1,000 or 1,500 milligram per day to get a very good effect. As doctors have said that at night time she had burning sensation in the back and the lower limbs, which was reason for his difficult sleeping. So this is probably more of neuropathic pain. Also, motor neuron disease patients have some kind of skeletal muscle spasm. So we need to give some antispasmodic drug because they tend to become spasmodic and the stiffness of the muscle. And here that comes the role of antispasmodic and intensive physiotherapy to take care of the spasm as well as to prevent stiffness. So morphine and use of and also what Dr. Raji has said that definitely if you follow the WHO analgesic ladder, it makes us imperative to try with some doses of paracetamol because paracetamol works centrally. So it could have it could have done some benefit in this case. So this is my opinion. Thank you very much.
As far as I remember, I think baclofen was added for anti-spastic drug, was it, Dr. Namrata? So what scale was the pain at present with the patient, like on the scale of 0 to 10 with 5 milligram of morphine and the other drugs?
Around 4.
Around 4. So initial, what was the number, the pain score?
Around 7, 8, 7.
So morphine did help, did it or not? So maybe as suggested, an increase in the dose of morphine can be considered and optimizing the dose of gabapentin for this patient along with, as Dr. Iqbal suggested, maybe imipramine, adding imipramine will also help. And physiotherapy, of course. Anything else to be suggested, ma'am?
Well, one other thing that I could imagine asking her is acknowledging, I understand that we We haven't made everything perfect for you, far from it. But overall, I would want to know, has there been any improvement in your quality of life with the things that we've done? Can you tell us which you think has the most quality, which made the most improvement in quality of life? And sometimes that moves you away from the numerical scale, but allows it helps me to get a better sense sometimes with patients if we've made any difference at all and what the patient thinks has made the difference. Some patients can't answer that question. They just say, I don't know, I'm taking too many medicines. But I find that narrative to sometimes be helpful. So you guys are really trying hard to help her. I salute your work.
So any more suggestions or questions, or we'll be closing the session? Namrata, do you want to say something? Oh, okay.
We'll try suggestions and we'll get back.
Can you say it again, Dinesh? I didn't get you.
We'll try the suggestions and we'll try the suggestions and come back with follow-up.
Okay, thank you. So thank you, everyone. Thank you for participating, and we'll be sending the summary and the suggestions shortly. And can we have a follow-up on this case as well next week when we do that day after next week? Okay, is that okay? Thank you. Thank you, everyone, for participating. It was a good session. Thank you.